Thank you, Carla, and welcome everybody, wherever you are in the world. So I'm not sure if it's good morning, good afternoon, or good evening that I should be saying to you. So the topic today for our webinar is about family carers, and particularly evidence-based interventions to support family carers in palliative care contexts. Now, as I'm sure you'll know, family caregivers are really crucial to the delivery of good palliative care and especially to care delivered at home. So we've got three excellent speakers today, and each of them are going to be talking for around about 20 minutes. So I'm sure during those talks, you'll think of lovely questions that you want to ask them. And we're hoping to have around about half an hour at the end. So do stay on the line for those questions and answer session. So I can see everybody's putting in their names and where they're from right now. But I'm going to start by inviting Jamie Pender, who's in the College of Nursing at the University of Manitoba in Canada, to be our first speaker. So over to you, Jamie.
Okay, thank you very much, Dr. Payne. I'll just share my screen. Okay, everybody can see that? Okay.
Yeah.
Okay, perfect. Thank you. All right, so thank you very much. I'm excited to be here. I will say good morning from Canada. And yeah, I'm really delighted to be here, and I'm grateful for this opportunity to share some of the work we've been doing around caregiver-friendly communities. In particular, today I'll talk a little bit about our process of community engagement, the development of a community action plan, which led to the co-design of a caregiver center that provides evidence-based advocacy resources and education to directly support caregivers, but also to equip the broader community to provide caregiver support. Before I begin, I do just want to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Innuit, Anisinainuk, Dakota Iote, Dene, and Inuit, and on the national homeland of the Red River Métis. We recognize that the treaties signed on these lands are a lifelong, enduring relationship, and we're dedicated to upholding their spirit and intent. We acknowledge the harms and mistakes of the past and the present, and with this understanding, we commit to supporting Indigenous excellence through active reconciliation, meaningful change, and the creation of an environment where everyone can thrive. Our collaboration with Indigenous communities is grounded in respect and reciprocity, and this really guides how we move forward as an institution. So a little bit of background, just to share with you why we got started with this work, why we engaged in this work. As in other parts of the world, the number of Canadians who are aging or living with a chronic progressive illness is increasing. In about 4 years, approximately 1/4 of our population will be over the age of 65 years old. And about 3/4 of these individuals report having at least one chronic condition, such as heart disease, chronic obstructive pulmonary disease, cancer, or dementia, those types of illnesses. And as you know, these illnesses are characterized by a progressive deterioration of either physical or cognitive function and affects an individual's activities of daily living, often requiring that they have added support or care and assistance from day to day. So alongside this, individuals often prefer to receive care at home, and the government here in Canada is increasingly making efforts to have healthcare costs, really, which has resulted in this growing shift away from institutionalized care into the community and at home. And so there's this increased reliance on care within the home where families are playing this very important role that Dr. Payne was talking about when she introduced the session. And the number of family caregivers is increasing as the number of these illnesses increase. So currently in Canada, we have just over 8 million family caregivers that are providing 5.7 billion hours of care. with an economic contribution of $97.1 billion. So it's estimated that if every caregiver would say, I can't do this, and would stop caregiving, our health and social care systems would collapse by tomorrow at noon. So they are certainly what has often been coined the backbone of our health and social care systems. The care that family caregivers provide is becoming increasingly complex and demanding. So despite little or no training, caregivers are often expected to provide medical and nursing care, navigate very complex and siloed health and social systems, which they've identified actually as the top burden for them. And they're acting as a substitute decision maker a lot of the times, or making decisions along with the care recipient. Most caregivers don't have access to caregiver-specific education and supports, despite evidence that these can improve their well-being and the well-being of the care recipient. So we know that caregivers report all kinds of impacts from the caregiving role. Caregiving can impact their mental and physical health, their ability to work, their ability to socialize and otherwise engage in family and social functions and take care of themselves. So we really do need to move beyond the status quo with the growing awareness of the impacts of caregiving. In 2011, it was a very exciting time here in Manitoba. We were the first province to introduce legislation through the Caregiver Recognition Act. And this legislation really was meant to promote programs and supports to be put in place to support family caregivers and improve the caregiving experience. And so in 2012, a colleague of mine, Dr. Laura Funk, surveyed caregivers here in Manitoba about their experiences to help inform some of the work that was going to be done through this legislation. And at that time, nearly half of family caregivers in our province reported needing a lot or quite a bit of help, particularly in the areas of navigating health and social care systems, communicating with healthcare providers, and coordinating resources. So from this work, recommendations were made to the government, to the Ministry of Healthy Living, Seniors, and Consumer Affairs to inform, again, those things that were coming out of legislation, the programs that were to be put in place. 10 years later, I partnered with Dr. Funk and we surveyed Manitoba caregivers again. And unfortunately, the same issues that caregivers identified a decade ago still exist in Manitoba. And of course, in that same time was the pandemic, which really amplified and unveiled the challenges that existed for caregivers. And so it was really disappointing to see that over 10 years, and despite legislation and other things being put in place, the needle sort of hadn't moved for caregiver outcomes and the experiences that they were having. During this same decade, in 2018, the government of Canada, Health Canada, rather, put out a framework on palliative care. And the aim of this framework really was to ensure that Canadians have the best possible quality of life right to the end of life. And that includes family caregivers. As we know, palliative care is aimed at improving quality of life for care recipient and caregiver. And one of the main drivers for this framework really were those changing demographics and the recognition of the impact, the increasing impact and pressure on caregivers. When we looked at the tenets of the framework and then looked at the literature to see what types of caregiver interventions were available, there were some interesting things that we discovered. So one of the tenets of the framework is that palliative care should include those living with any life-limiting illness. And yet, among caregiver interventions, a lot of times the interventions are predominantly focused on cancer and dementia populations. The framework also outlined that palliative care can be provided throughout the illness trajectory, not just at the very end of life. And yet many interventions are really focused on that end of life phase and into bereavement. The framework talks about how palliative care should be delivered in a range of settings. And again, we found that many caregiver interventions were developed in urban settings or hospital settings, fewer in rural settings or in the community. The other interesting thing that we found was that a lot of the caregiver interventions were really developed largely at the individual level of the caregiver. So intervening with the caregiver themselves to teach them this knowledge and skills that they need to provide care and skills that they need to cope, which are not bad. Those are good things and they're needed. But there were very few interventions that were broader level interventions. So there were some, though, and increasingly they are starting to happen. For example, in Canada, we've got a national co-design team led by researchers out of Alberta, developing caregiver-centered care competencies for healthcare providers and others to support caregivers. There's also this notion of compassionate communities that is really, I know, big in the UK and has been taking off here in Canada as well, and where aging, dying, caregiving, and grieving are really seen as everybody's responsibility. So broader than the individual caregiver, and intervening to those around caregivers to help them have a better experience and better outcomes. But more of those broader level interventions are needed. So we took a look at what was happening in Canada. And at the time, here I'm showing there's 5 provinces that have provincial caregiver organizations. At the time, there was only 4. New Brunswick has since also developed an association, which is fantastic. So we have 5 caregiver organizations in Canada and 5 of our provinces. We also have the Young Caregivers Association and the Canadian Centre for Caregiving Excellence, which is a more of a national organization looking at policy and bringing all these organizations together as well. So lots of good work happening. But in Manitoba, which is the dark blue spot there in the middle of the map, that's us right in the middle of Canada, there really was nothing happening, and we have no provincial caregiver organization. So considering all these things, we began to wonder, how can we better support caregivers in Manitoba specifically? And we were thinking about, if we're going to move that needle on caregiver outcomes, we really need to be in tune with and responsive to the caregiving context and their experiences. And interventions that are developed or delivered, by healthcare providers in healthcare settings are certainly important, and they're definitely necessary, but that intersection with family caregivers is often quite small. Caregivers spend most of their time in the community. And so thinking about how can we develop interventions to support caregivers where they spend the majority of their time. Family caregivers also have needs beyond the provision of care. So we know that caregiving impacts all facets of their life in all domains. And so we need to understand and respond to these needs. And we know that interventions are taken up and are more effective when the end users or the caregivers are involved right from the beginning. So needing to get them involved in the development of these interventions. So drawing on some of the tenets of compassionate communities, and there's age-friendly communities, dementia-friendly communities. We conceptualize caregiver-friendly communities, drawing on the literature as well, to be communities in which community members are educated about caregiving, respect the contribution that caregivers make, recognize that they have specific needs, and provide support to address these needs. And when we say community members, we mean all community members in all sectors, recognizing needs in all domains and providing supports in all those domains as well. And by doing so, the hope is that caregivers' own health can be maintained and they're enabled to continue to provide care if they wish to do so. And the community also benefits by having healthier community members and being better prepared should they assume the caregiver role themselves. So again, understanding when we look at intervention development, understanding that interventions that are theory-driven, co-designed, and use an integrated knowledge translation approach are really important because getting feedback from stakeholders helps us to ensure that interventions are relevant and appropriate. And this feedback can also help guide the development or help refine the intervention as well to make it more acceptable. Interventions that are more acceptable or more relevant obviously will enhance the favorableness of that intervention, which in turn enhances their uptake, the implementation, and the effects on the outcomes. So with that in mind, the theory that we chose to work with was that of appreciative inquiry. It was the framework that guided this work of developing a caregiver-friendly community. And this is really an approach to changing organizational systems by exploring the positives or the strengths of an organization in the past and their present strengths in an effort to generate a collective vision of a new and better future. So oftentimes traditional approaches will focus on deficits and or problems and addressing those deficits or problems. But appreciative inquiry rather focuses on seeing and valuing the best in people and systems and capitalizing on that and leveraging those strengths to generate new ideas and employ actionable strategies towards change. The method we used for this work was a collaborative participatory research design to elicit input and feedback from community stakeholders to inform the design of a community action plan. And this approach really is consistent with appreciative inquiry and acknowledges that both the researcher and the community stakeholder have expertise that's essential to creating this effective and meaningful change. So the first thing we did was we established a working group. So there were 9 individuals in the working group, and this working group was comprised of various stakeholders. We had family caregivers, we had representatives from City Council, the Chamber of Commerce, the Arts Council, the Regional Health Authority, senior centers, and social care organizations. And we chose to engage with a rural community in Manitoba that has about 16,000 people. It's a bigger rural community, but it's still considered rural. So we formed this working group of key stakeholders within that community. And this working group met about 6 times over the course of a year to guide, their main purpose was to guide the development and implementation of community engagement activities. Our first engagement activity with the community was that of conducting focus groups. So we held 8 focus groups with various sectors in the community. On the left, there is a list of the groups that we met with. So we had 2 focus groups with family caregivers, 2 with healthcare providers. And then we met with a group of nonprofit organizations, social care organizations, employers, and church leaders as well. And the idea here really was to engage with each of these groups to get their perspectives on what they viewed the caregiver role and experience to be like, their understanding of how caregivers were currently being supported in the community, what they thought a caregiver-friendly community would look like, and what they thought some of the strategies would be that we could take as a community to get there, and what outcomes might be meaningful for both caregivers and for the community at large. And so these focus groups were about 90 minutes in duration, and this happened during the pandemic, and so the groups were held on Zoom. The caregivers themselves told us that they had needs related to both providing care and maintaining their own health and well-being. Interestingly, though, the themes that came out of the other focus groups, other community members were able to identify largely what caregivers may need to provide care, but they less often recognize the impacts of caregiving on caregivers' own health and well-being and social functioning as well. When they talked about what supports existed, they acknowledged that several supports still do exist, so there were some strengths in this community that we could leverage, but that those supports only targeted a small number of the needs related to providing care, such as equipment or personal care. And they also talked about challenges identifying and accessing these supports and a need for more of them. So many needs related to providing care remained unmet, and there were few supports that existed to address caregivers' own health and well-being. such as their own feelings or worries, work issues, financial, legal responsibilities, those types of things. When they talked about what they envisioned a caregiver-friendly community would look like for their community, they described it as one that would value aging, illness, or death as a natural part of life, respect and value caregivers in all parts of the community, and support caregivers during and after caregiving. And really, every group in some way, shape, or form talked about the fact that at the heart of this would be a hub for caregivers and community members to come and connect and receive help with system navigation, education, and other support. When they talked about how they thought this would benefit, they thought caregivers would benefit by being increasingly prepared, have better well-being and access to consistent support, and decrease feelings of being isolated, overwhelmed, or stressed. And they felt the community would benefit by increased connectedness, awareness, and engagement in actively supporting caregivers, and decreasing hospital admission and lost days at work for employed caregivers. Some of the strategies that they talked about towards becoming a caregiver-friendly community were really about raising awareness of family caregiving, educating different sectors about caregiving and the impacts of caregiving, establishing champions in the community to take up the cause and start to strengthen caregiver supports in the community, identify and coordinate existing resources and supports, and then develop new initiatives to address gaps and enhance the supports that were already there. So the third step then was to host a community forum. So we invited, we worked collaboratively with local media outlets to invite community members to participate in a forum. And again, this had to be virtual because it was during the pandemic. So it was about 2 hours long. We had 48 participants that came to the community forum. And the purpose really was to share about family caregiving and some of the supports that do exist in the community, present the results of the focus groups, and facilitate some roundtable discussions or small breakout room discussions to share and prioritize ideas around what to include in a community action plan. We took the information from the focus groups and from this community forum and went back and worked with that initial working group to develop a community action plan. And the community action plan really defined clear goals and created a detailed plan with specific action items, timelines, and responsibilities for how we would achieve the goals that were set. And alongside this, what was developed and continues to be developed is an ongoing data monitoring and evaluation plan so that we know if this is being successful. But really what kept coming up here is this idea, oh, I'm almost done, Sheila, one more minute. What really came up here was the importance of that hub. The community really talked about needing that hub to lead this work. And so this is where Care Manitoba was born. So Care Manitoba is a new nonprofit organization that was born out of this community group and this collaborative work. And it was really designed to be this hub to carry out this community action plan and the vision that this community had for developing better supports for caregivers. So we have a board of directors, we have an advisory group made of mostly caregivers, but other community members as well. And we got an in-kind donation from a local organizational development agency to help us with our organizational clarity statements and our strategic plan, which largely reflects and integrates those priorities from the community action plan into that. So it's really existing to support and empower caregivers to thrive. There's the two prongs, there's the direct support for caregivers, but then there's also the capacity building within the community, which is a big part of this work. And it's all evidence-based. It's exciting. Along this whole time of development, we've had nursing students come in for their clinical rotations to help with some of the development, which also engages them in experiential learning around supporting caregivers. We've had senior groups come in and help with some of it as well. Some of our political organizations have been involved as well, which has been kind of exciting. So it's great because this is our first formal caregiver organization in our province. We're really driven by this connection, collaboration, and community. We're aiming to build that capacity within our community, and it's an innovative approach. And so what we're really working towards is taking this model, and rather than having one central hub that does outreach, which is good, and that's a good model that can be effective as well, the caregivers in our group really talked about wanting very tailored supports and resources that were local. So we're keeping it really local and then replicating this model in communities throughout the province, so that we'll have chapters almost of Care Manitoba throughout. So in a nutshell, that's what we've been up to, and our work towards developing a caregiver-friendly community. Thank you.
Thank you so much, Jamie. It's really impressive what you've managed to achieve. And I can see lots of people clapping you online. That's wonderful. And it's impressive that you've engaged so well with different stakeholders. So as I said before, we won't take questions from you right now, but there are people I'm sure who will have questions for you, and we encourage you to post them in the chat. So we're going to move now to our next speaker, who's Viktoria Wallin, who's in the Department of Healthcare Sciences in Stockholm in Sweden. So we've crossed the Atlantic now, and welcome, Viktoria, for your talk, please.
Thank you very much, Sheila. I think my pictures are loading. So thank you very much for this opportunity to share results and some reflections from the research where I'm partaking. And this is a web-based psychoeducational intervention aiming to promote family caregiver preparedness. And I'm not this alone, as it looks like here when you only see my name. I'm part of this research group led by Annette Alvareza, our professor. And this research project got funding for research and also for implementation. So the website I will talk about, it is now open and free to access for family caregivers. And it's called närstående.se, and this means in English family caregivers. And the subheading, you can see the smaller white letters there. It means support for you where you are. That's what we have tried to give the family caregivers. And I had an excellent introduction done from Jamie. Thank you for that. It is known that family caregivers often have unmet psychosocial and informational needs. And preparedness for death of a person include both cognitive and emotional aspects. Preparedness has been shown to be protective for family caregivers and reduce the risk of negative consequences. Support for family caregivers can increase preparedness. And in this project, we have been focusing on web-based support. And why this? Web-based support can be an alternative to face-to-face support groups. Delivering interventions in real life is time-consuming for healthcare professionals. And furthermore, it may not appeal to all family caregivers, and leaving home can also be difficult when you're caring for a person at home. During last years, a variety of web-based interventions have been developed, and positive effects on emotional support and decisional aid, for example, has been shown. Web-based interventions have the potential to be cost-effective while offering family caregivers accessible support. So web-based support can be an alternative. Therefore, this web-based psychoeducational family caregiver targeted intervention aiming to promote preparedness was developed. The website offers videos, text, and links, and they are based on research about family caregiver needs. The content is organized into 3 main domains: support for you, being a family caregiver, and the second one, how to give support, and the third, talk about it. The topics relate to caregiving as well as dying and death. The videos show conversations between family caregivers, played by actors, and authentic healthcare professionals, and they are addressing common questions and support needs. Each video is clearly labeled so caregivers can easily choose what they want to access. What do I want to take part of today or at this moment? The videos are texted and also supplemented by informative texts and web links. The videos, sorry you can't read Swedish and the English labels are maybe small to read here, but the videos touch on things that relatives often have questions about and need support for, such as the dual roles that it means to be a family member and at the same time a family caregiver. Okay, a little bit of the content of the videos. I described that it was about the dual roles, being a family caregiver and family member at the same time. And there are also about how to participate in care according to one's own wishes. And about spending time together to talk about illness, feelings, and future life. And there is also content being more practical, such as symptom relief, treatment, or diet. After constructing the website, in the first phase, the website was tested. And I tried to change slide. I hope it changed for you. And when testing the website, 39 family caregivers were recruited from specialized palliative home care services. And after baseline questionnaires, they were given access to the website. A 4-week follow-up questionnaire was sent and complemented by interviews. This testing of the intervention demonstrated acceptability and usability. The online format was appreciated and considered flexible, and the intervention content was found informative and suited to their situation as family caregivers. All participants would recommend the website to others in similar situations. The participants had mostly used the videos, to a lesser extent the text and web links. However, not everyone had used the website. Some participants expressed a wish for support in real life instead, so one size does not fit all. And I'm not friend with my computer today. Some words about another study from this first data set showed a significant association between preparedness for caregiving and preparedness for death. Received support and communication about the illness was associated with higher levels of preparedness for caregiving and death. And this study contributes to evidence on the association between preparedness for caregiving and death, but also that communication and support employed by healthcare professionals could improve family caregiver preparedness and well-being. And I guess you are now wondering about the RCT, and that was the next step. A 2-arm randomized controlled trial was conducted, and altogether 205 family caregivers were recruited from specialized palliative home care services. They were randomized, and 103 were given access to the web-based intervention after completed a questionnaire. And questionnaires were sent at baseline 4 weeks and 8 weeks, and also 6 months after the patient's death. And we conducted interviews with family caregivers and patients, both individually and as a couple, at 4 weeks follow-up, and family caregivers also 6 months after the patient's death. And I start with some qualitative data from these. Interviews were performed with 70 family caregivers, most of them spouses. And the qualitative findings show that the intervention resonated with the family caregiver's situation and gave comfort and awareness. They valued having access to the website. The intervention inspired self-reflection on the caregiver role that provided new insights and encouraged communication with the patient. And the intervention also prepared family caregivers for the patient's progressing illness and death. Preparing was a help for some participants. Others did not feel ready to face this, which led them to avoid parts of the website. I want to share a quote from a participant that illustrates parts of the teams. I turned to the website when I felt particularly lonely, really low, and just needing support. It's been helpful during those times, allowing myself to cry and truly feel how things are, because sometimes it can be tough. Identification and comfort are what I would call it. I feel sad when I see something that resembles my situation. At the same time, I find it comforting too. And after that, interviews were also conducted with couples, and in total 32 participants were interviewed, 16 spouses and 16 patients. And this was after the spouse had accessed the intervention for 4 weeks, and they were interviewed as couple at the same time. Couples described how the spouse's access to the intervention had provided knowledge that had enhanced the couple's understanding of each other's strategies for managing the impacts of the illness. The topics covered in the intervention prompted the spouses to initiate conversations that helped couples maintain a sense of mutuality. Further, the intervention provided support to balance the tension between previous and new relational roles, which had changed due to the patient's illness. So, altogether, the results show that the benefits of family caregiver-targeted interventions may extend from spouse to patient, facilitating their everyday life. Our findings complement previous intervention evaluations by providing insights into how they may manage, how they may be effective. Okay, and what about the intervention? What happened in the RCT? So we wanted to investigate whether the web-based intervention could improve in preparedness for caregiving among family caregivers of patients receiving specialized palliative home care. So the intervention did not show any significant effect on preparedness for caregiving. Even though we included subgroups based on level of baseline preparedness for caregiving, participation in physical care, or active intervention use. However, all subgroups reported higher levels of preparedness for caregiving at both follow-up assessments than at baseline. The preparedness did improve. So preparedness for caregiving improved over time in both intervention and control groups, suggesting other contributing factors then, and maybe limited participant engagement may explain the lack of intervention effect. Before reflecting a little bit about that, I want to share with you another study from this data set where patients were interviewed, 22 patients. In Sweden, when we should do this study, we needed to ask the patient to nominate their family caregiver. Due to ethical reasons, we could not pick names and telephone numbers to family caregivers from the patient records. So this might be a risk for gatekeeping, and we wanted to explore that further. And 22 patients did partake in individual interviews here. And the patients did nominate the family caregiver out of concern and recognition of the emotional and practical burden they faced. And they wished for the family caregivers to be offered support. The patient's choice was mindful, and they refrained from nominating persons whom they perceived as too frail or too busy. The patient expected the intervention would encourage conversations about topics that had previously been avoided. Okay, it's time to sum up and share some reflections. So the qualitative data was positive and promising, but there were no significant effects on preparedness for care. How can we understand this? The study had a pragmatic design. Family caregivers freely choose which part of the website they wanted to use and how much they wanted to engage in it. And one could here question whether the approach was perhaps too pragmatic. There was no tracking of actual website use on the website. Instead, intervention use was assessed through a self-reported question only. Future studies should maybe evaluate the intervention with more structured and clinically integrated use. That would be great. Looking for money for that if you know some money somewhere. And I can also add that healthcare professionals all over Sweden have been very positive. The website is now open and it's shared and it's spread very much. And that is also the kind of result that it is so appreciated, I think. This is a large study. We have lots of data and ongoing studies to look out for in the future for you, hopefully. We are looking at family caregivers' health and quality of life and associations there. We are looking at effects of preparedness for death, of course. And another interesting studies, I think, are communication about approaching death and also cognitive and emotional preparedness for death. And with that, I want to say thank you very much for listening and looking at my jumping pictures here. And you're welcome to contact me if you want to, of course. And here is a list of publications so far from this research project. Thank you.
Thank you very much, Viktoria. And I loved all your beautiful watercolor pictures and, of course, your important research that you're reporting on. I'm sure that people will have some questions for you later. So we're going to thank Viktoria and welcome Silvia Gonella, who is from the Department of Public Health and Pediatrics at Turin in Italy. So over to you now, Silvia. I think you're going to tell us about the InTouch study.
Sure. So my presentation is focused on the area of dementia care and particularly I will provide a little bit of context around the need to support the family caregiver of a person with advanced dementia, and then I will move forward with sharing with you a couple of research projects where the University of Torino has been involved in. These are two transnational projects where two great consortium have been engaged. So we all agree on the point that dementia is a public health and social care priority everywhere, with around 57 million people living with dementia worldwide, and that this number are estimated to almost triple by 2050. And also, we all know that around 3/4 of the people with dementia move permanently at some way of their disease trajectory in the nursing home setting due to an increasing level of disability and dependence, because their family caregivers are no longer able to care for them in the hospital setting. Anyway, this transition does not necessarily signal the end of caregiving, but rather it represents a new phase in the caregiver, in the caregiving trajectory, because caregivers continues to usually occupy a very essential position in the decision-making process as a surrogate decision maker after their relative moves to the nursing home. And so their burden often persists after this transition and increases near the end of life. As you can imagine, all these data suggest that family caregivers of persons with dementia need continuous support. And this is confirmed by the World Health Organization Global Action Plan on the public response to dementia, that highlights the need to support dementia carers as one of the 7 areas for action. And recently, the palliative care goal models for people with dementia and their family that has been developed starting from the EAPC white paper on dementia palliative care underlined the need to provide family caregivers of persons with dementia with support that need to be tailored across the disease trajectory, because caregivers' needs in terms of emotional, psychosocial, but also the practical one are likely to change over the disease trajectory, and particularly in the very advanced stages, and particularly when the person moves towards the end of life, family carers are really in need to be supported with the difficult decisions that are likely to be made. And so with regard to the intervention that were shown to be useful to support dementia carer, I'm going to share with you 2 experiences. The first one is the My Support study. This is an educational intervention that was originally developed and implemented in Northern Ireland and then scaled up across 6 European countries, and then the In Touch project, that is a project that is currently ongoing. Starting from the My Support study, this was a transnational multidisciplinary implementation study that took place during the pandemic period, and that involved 6 countries, particularly Canada, Czech Republic, Italy, the Netherlands, the Republic of Ireland, and the United Kingdom. And this study took place in the nursing home context and targeted the family caregivers of people with advanced dementia, with the aim to adapt and assess the family care's decision support intervention, and also to assess the impact of such intervention on family satisfaction and the decision-making process, and finally to identify the cost of this intervention, but also to highlight potential barriers as well as facilitators that may promote or hinder the implementation of the FCDS. So this intervention was an educational intervention that aimed to inform family caregivers about end-of-life care options that are available to a person living with advanced dementia in order to enable their carers to participate in an informed decision-making process regarding the end-of-life care. The FCDS has 3 core elements. The first one is the training of the nursing home staff that is supposed to provide the FCDS intervention, some written educational resources, and then the delivery of the family care conference. Starting from the first component, we adopted a train-the-trainer model where the nursing home staff was trained to deliver the family care conference, and this training involved both an e-learning and digital support resources, but also ongoing support by a trained external facilitator to the nursing home. With regard to the second component, here in the picture you are seeing the comfort care booklet in its Italian version that was employed during the project. This booklet is available in multiple languages, and it was also adapted to the local context. And this resource provided the family carers with information in order to make them better understand the risk and benefits of the different care option towards the end of life. And so this allowed them to be really actively engaged in decision making. This booklet covers 5 main topics around the natural evolution of dementia, the decisions that are likely to be made at the end of life, the kind of symptoms you're likely to expect, and what we can do to provide some relief, and also the final moments and what happened after death. This booklet was supported by a list of questions because often family carers have a lot of doubts and a lot of questions, but they are in trouble to formulate them in a right way, and so they feel stop. And this question prompt list work as a discussion prompt to initiate but also sustain the discussion. And finally, the third component is represented by the family care conference. This is a 1-hour meeting that involved a trained member of the nursing home staff. We refer to as the internal facilitator, but also there was the opportunity for other staff members to join. And similarly, beyond the family carers of reference, other significant others and other family members could join the conference. The meeting had a very clear structure constituted of preparing, conducting, documentation, and follow-up phases, and it was based on clinical practice guidelines and also underpinned by the REMAP framework. This framework is a framework that is really useful to support meaningful care conversation. And within this framework, the professional is expected to open the conversation by exploring the understanding of the person with regard to the awareness around the disease prognosis and decisions that are likely to be made in a short time. And this kind of interaction may may trigger important emotional responses, thereby the professional is expected to acknowledge and validate such responses. And then we move forward in exploring what matters the most to the person by employing open-ended evocative question. And finally, we move towards the alignment of the care plan with the person values by shifting from evocative question to summaries and more reflective pieces. And finally, the professional closes with a proposed care plan that should be consistent with the goals that have been just emerged over the interaction. Just to share with you some brief results from the My Support study, overall 88 family caregivers were involved across 12 nursing homes in 6 countries. And these family caregivers fill in the decisional conflict scale and the family perception of care scale before the intervention and after the intervention. And we found less decision-making uncertainty and more positive perception of care after the intervention. So this data suggests that this intervention is transferable across countries and also highlights the role of educational support in reducing decision-making uncertainty and also in enhancing family satisfaction with care. Moreover, we shed light on the factors that may influence the implementation of the intervention, and particularly we identify the role of a supportive relationship, the role of commitment of the staff, but also the perceived value of the intervention, the importance to have a resource available. All these factors positively influence the implementation of the intervention. But at the same time, there were some unexpected external factors, and particularly the COVID pandemic, that represented some barrier, and extra strategies needed to be put in place to overcome these issues. So overall, this data suggests that the FCDS is a sustainable intervention that in a way requires protective time of the staff, but also some kind of flexibility of the organization. And it worked particularly well when there was good collaboration among the staff member. With regard to the cost, as you can see from this number, the costs were pretty limited, with 46 internal facilitators that were trained, and with a cost of less than 400 euros per internal facilitator. So overall, the intervention appears economically sustainable, and the investment were a primary focus on the initial training. Then moving forward towards the current In Touch project. This is a European-founded project, and it's really an ambitious project that involves 13 institutions across Europe, United Kingdom, and Canada. And the intervention designed within the In Touch project has been designed as a two-arm parallel cluster randomized trial that will involve the 56 nursing homes in 7 countries, with an embedded process and economic evaluation. And differently from the My Support study, the In Touch is really a dyadic intervention, where we are looking to not only the family caregivers, but also the residents, the people with moderate, severe to severe dementia. And particularly this in-touch intervention is constituted by two synergistically interconnected interventions. The first one is the FCDS, so the intervention I just mentioned you right now, and the idea is to look at the family caregivers of people with dementia, and it's focused on providing dementia carer some kind of support to plan future care. So it will be run as aforementioned, so the training of the staff, written resources, and the family meeting as well. But in addition to this, there is also a second component that is constituted by the namaste care intervention that instead looks at the resident, the people with advanced dementia, and it's a focus on the in the moment care. So we have both in the moment care and in the future care. With regard to in the moment care, we refer to meaningful activities where people with dementia are engaged in a group setting, because the aim of this intervention is also to promote social connection and to promote relationship among people. And within this moment of sharing, people are involved to sensory stimulation that involves all the senses, and this stimulation is pretty tailored on the personal values of each person based on their life history. So it's really a personalized intervention based on the knowledge of the person values and the preferences. And all this intervention is provided within a dedicated space. The combination of these two interventions constituted the in-touch intervention that aims to improve both the quality of life and social engagement of people with dementia, but also to offer support to their caregivers. The main aim, the primary aim, is to determine the effectiveness of the in-touch intervention on a wide range of residents, family, and staff outcomes. But also we have some secondary objectives, and particularly we would like to assess the cost of delivering such intervention, and we also would like to identify the potential barriers and facilitator to the implementation. And finally, to explore the mechanism for supporting the adoption and the sustainability over time. And indeed, we are going also to finally provide a set of recommendation and policy brief to provide guidance in the implementation and the sustainability over time. With regard to the family outcome, because this webinar has this focus, I can say that the main outcome are represented by family satisfaction with care of the residents, but also the decisional conflict, anticipatory grief, quality of life. To note also, we are going to assess the understanding of families as dementia, as a disease you can die from. And in the case the residents dies, also the comfort in dying and the post-bereavement grief from the perspective of the family caregivers will be explored. So our cluster randomized controlled trial is going to start very soon in spring 2026. So if you are interested in knowing how the project moves forward, please follow us on our social and also on our website. Thank you very much.
Thank you, Silvia. I'm sorry it was a rather difficult start for you with the technical issues, and thank you for everybody who's managed to log on and continue with us on this new site. All the recordings have been made, so they will be available to you to listen to and watch in future. So we've got a little time, about 10 minutes now, for some discussion. So please post any questions that you have on the chat function, and I'll be able to read them out for our speakers. And I've got one to start with, and I'm going to start with you, Silvia. It seems that on a lot of the projects that we've heard about today, there are issues about recruitment. So the question that we have posted on the chat is, what advice on strategies do you have to increase caregivers' engagement in intervention studies?
Oh, I really agree with this point, because it's not easy to conduct research in the nursing home context, and particularly when nearing the end of life. So the strategies we adopted in the My Support study, and we are putting in place also right now, is to have frequent in-person contact with the nursing home manager. So they really need to know you, to meet you, and so you need to be open to understand their point, their perspective, and you really need to be in their shoes to understand the difficulty they are living, also in terms of staffing. And so together try to identify the best strategies that may help to enter this kind of project. So my advice would be to be as much open as possible, and also to be very flexible in terms of project management, because it's really terrific, and I would say almost impossible, that a nursing home manager, for example, for the In Touch project, I can say this experience, would immediately embrace the project in its shape, but together it can be useful to find the strategies that help to be very stick to the core principle of the project. So it's possible to guarantee fidelity to the core component of the intervention, but also to have some kind of flexibility and to be open to the request of the person who work in the organization.
Thank you, Silvia. So we have a question now for Viktoria, and it's from Claire. I'm just getting it up on my screen. You were complimented on your presentation, Viktoria. Can you talk about your choice of outcome measures for your trial? So Viktoria, if you're able to unmute and put your camera on.
I think I've done. Did I succeed? They are
yes,
our
good.
outcome measures. They are based on earlier research where we have seen that this could be sensitive in this kind of research. So we were actually very hopeful and eager to see the results, but we couldn't see any effects. We have secondary outcomes also as health and well-being, and as the primary didn't show anything yet, we are not that hopeful about that. It made me think also when you answered now, Silvia, it's also a delicate balance. I mean, I've been the project coordinator in our project and helping the family caregivers in the control group, not being too helpful, because I can be an intervention myself, if you understand how I mean. Of course helpful, but if the control group get supported very much, maybe that can have an effect as well. Just sharing some thoughts here. What do you think?
Thank you, Viktoria. I think I'm going to Jamie next, because Jamie, it seemed you were very successful in engaging different stakeholders. So what were the secrets that you'd like to share about how you did that? And particularly carers who often have many pressing issues that they're dealing with. How did you get them so involved in your research?
Thank you, Dr. Payne. That's a great question. So it was really daunting at the start to think about how are we going to engage so many different sectors in the community, including these caregivers who are overwhelmed during the pandemic. And so there were lots of challenges there. But I think one of the key components for the work that we did was that working group. So we engaged sort of some key stakeholders early, got them excited about the project, that we had their buy-in out of the start, and they helped to recruit and help us to develop recruitment strategies in the community, knowing their community really well and knowing, how we would be able to reach individuals and what would work to not only reach them, but engage them and interest them in the study. Caregivers themselves, I mean, we were quite active in our recruitment for the study. So we did presentations with different organizations or different places where caregivers might be. So we did, presentations in workplaces, we did presentations in churches, we did presentations in, all kinds of different places. And caregivers got excited about the fact that we were hoping to develop something that could help them and others in their situation. And so it wasn't actually a hard sell for us. What was tricky was getting them engaged during the pandemic and having to do everything virtually. So, yeah.
So that was a big challenge for many researchers, but we kind of had to learn a whole new range of skills, didn't we, to do our activities online. And we're still facing technical issues now, as we've discovered in our seminar today. But we've got a question from Patrick, and this is for you, Silvia. And he's asking, would it be possible to assess the implementation costs if the intervention is not provided on caregivers' quality of life and the impact on their grief? So I think he's asking about the costs of the intervention and what are the best outcome measures to base that cost on.
I guess the question is related to the InTouch project. So we are mapping right now which are the potential costs, and we mean both the direct cost, the indirect cost, and with cost we will have a very broad approach with regard to both the training of the staff, but also a cost relating to medication provided to the residents. For example, all the psychotropic drug, for example, that we are expected to reduce after the intervention, but also we will take a look also to the cost related, cost more difficult to quantify. For example, the time the caregiver takes to go to the nursing home to visit their care. So we will embrace a very broad perspective in determining the cost at different level. And yes, it would be possible to assess this implementation cost. Also, if we will not have the post-grief, post-death results. No, I hope I answered the question.
So I'm going to draw this webinar to a close now, and thank you especially to Jamie, Viktoria and Silvia for your fascinating talks. I think each of you has focused on slightly different but equally important issues for family caregivers.